speaking to you about measuring what matters in public health. And the reason I chose this is because of how often we get it wrong. We don't pay attention to rigor in many things, and when you are looking at situations that are particularly heterogeneous, and humans and the environment are very heterogeneous, then you need to know that your measurements are really correct. So I'll start with something that we are familiar with. It's been in the news. This is deaths due to COVID-19. And if you look on top, this is the Economist's estimate of the number of deaths, 26 million. And the official figures around the world are about 6 million. Now, if you look at the map that you see on the right and compare it to the one here, this is the official rates per 100,000 people, COVID deaths, and there you have the economists' estimates of what really happened. Now, if you can look there, you can see that there is a difference between the two graphs. You have some countries like Canada that seem to have overestimated their deaths, and you have other countries, the bulk of countries, that seem to have underestimated their deaths. Now, there are a lot of reasons, a lot of discussions that have happened in the past few months to see why did this happen, and every country seems to provide a different reason. Now, if we actually look at the Indian data, this is data taken this morning from the Ministry of Health website, and what it shows us is the number of deaths that have taken place. In red are the deaths in the non-vaccinated. In blue, which you can barely see down at the bottom, is the deaths in people who received the first dose. And in green, again, the line right at the bottom is the deaths that you see in people who have received 2 doses of vaccine. There isn't data yet on booster doses. Now, I'd like you to look at this. That clearly is the Delta wave. This one is the Omicron wave. You remember when the precautionary dose was announced? At the beginning of January. Was there a reason? Based on our own data, there is no evidence that the country needed precautionary doses for anyone. Yeah. You could argue that this is something that is very age dependent, but go to the website and take a look at it. You see the exact same pattern in people who are over 60 years of age. So the government's own data does not tell us that we need a booster dose of vaccine. And we are the only country in the world that seems to have data that looks like this. Now, I'd like to show you something else. Our official death estimates, just over 500,000 people. It's been estimated by others that it is somewhere between 3 and 10 times the official estimate. But I want you to compare Maharashtra and Uttar Pradesh. Maharashtra, 125 million population. Uttar Pradesh, 231 million population. Number of cases in Maharashtra, about 8 million. In Uttar Pradesh, just over 2 million, with double the population. And if you look at deaths, Maharashtra has 150,000 official deaths, and Uttar Pradesh has 23,000, a sixth the deaths, with double the population. Now, is this true? Maybe Uttar Pradesh is the mecca of healthcare in the country. That's why nobody dies there, right? But then look at seropositivity data, which is a measure of who has been exposed to the virus or not. And what you see there is something that's very different. Maharashtra's seropositivity, the proportion of people that were infected at the exact same time was less than the proportion of people that had been infected in Uttar Pradesh. So we know that data doesn't really add up. So what I'm going to talk to you about very, very briefly across all of these points is looking at a variety of issues that I think are critically important for public health in India. Now, WHO actually has 100 indicators that measure how health systems perform. Some of these we are familiar with: stillbirth rates, neonatal mortality, maternal mortality. And these, all of them taken together, fit into different categories. The first is in blue, the health status of the population. And if you look at services, you have indicators like antenatal care coverage, how many births are attended by skilled birth attendants, etc. So there are a lot of things being measured in these 100 indicators, but they are really about structure, process, and outcome. And if we just look at mothers and the care that they get during their pregnancies, you can look at the indicators by structure, process, or outcome. Now, in the work that we have begun to do, and this is something that is currently occupying a lot of my time, is to try and address this question of, are we doing the right thing in our healthcare system? We pushed people to go to facilities for their babies to be born. And automatically we think that if you go to a bigger hospital, the care is going to be better. So what you wind up with is women that don't need tertiary health care winding up in a hospital that offers tertiary health care. And women that have complicated pregnancies with high risk factors don't actually make it through the system to get the quality of care that they really need. So what we are working on now is, how do you make sure that resources are appropriately allocated and referral pathways are created so that women get the kind of care that they need and the health system is not overburdened by providing high level care where it is not needed. This is not simple, and we've begun to look at this in Haryana and in Assam. And for us, what we are finding is that when we begin to look at indicators and measures, we cannot correlate anything that we find in the field with the official government figures. So literally, you have to build systems from scratch to try and figure out pathways to care that make sense. So these are the areas and places that we are working in. The place that we work in, Karimganj in Assam, actually has a maternal mortality rate that is 2.5 times the country's average. So it's a challenging place to work in. Currently, it's in the Barak Valley, they are flooded. But we hope that if we can get our methods right, we will be able to do something useful. The second issue I'd like to highlight to you is making a problem visible. How do you bring something to the attention of health authorities? Now, everybody knows typhoid. In our communities, typhoid is an illness that all of us and our families are familiar with for one reason or the other. But there is a problem. Doctors actually don't believe that typhoid is a problem anymore. This is a systematic review that shows that over time, typhoid has declined in India. And in Delhi, when the government introduced typhoid vaccination, doctors actually protested and said there was no need for the vaccine. We thought that people were wrong, and we set out to build another new system to try and identify how much typhoid there was. This was surveillance for enteric fever in India that we established in all of these sites. And our issues really was typhoid is actually a tough challenge because you need blood culture. And you need to be able to do fever follow-up, diagnostic confirmation, and follow-up for outcomes. So we wound up building this humongous system across 18 sites, following 25,000 children once a week to figure out whether they had fever or not. After 4 years, we wound up with a result that shows that in Delhi, Kolkata, and Vellore, the overall incidence of typhoid is over 500 per 100,000 child years of observation. In Pune, it was 38, and WHO's definition of highly endemic is above 200 per 100,000. Why did we need to build this system? Why should researchers be doing this kind of thing? This is something that should be done by public health authorities. But public health authorities use the Vidal test. Makes no sense whatsoever. The kinds of facilities that should be measuring this don't have blood culture machines, don't know that if a patient comes in with more than 2 days of antibiotics, your test is likely to be negative. So building out the right kind of measurement can be extremely challenging. Then we come to standardization. This I learnt the hard way. I started out following a cohort of children, and we were measuring what happened to them in terms of diarrhea. I did not know that if when you are below 12 months of age, your length should be measured lying down, and once you become older, it should be measured standing up. So that meant that when our children crossed from 1 into the second year of life, their heights actually came down. Now that makes no sense. It's not a mistake I have made again, but this is something that we really need to be able to understand why we need to measure accurately. It's been estimated that in most countries, when you measure heights, you get it wrong in about 42%, in 50%, and in 62% of people where you are measuring it. Okay? So I think looking at that is really important. And why is it important? Because actually when you look at stunting, we find that for stunting, it correlates with how children grow and their cognitive development. And when you measure heights, it's a problem. Can you imagine trying to assess IQs? So for that, the different components that need to be measured, how you standardize those measurements becomes even more challenging. We found a median IQ in the slum areas we were working in of 89 as opposed to a normal of 100. And we didn't know whether this was a true finding or not, because if we had two different assessors, we wound up with a variation of 3 points. Between 89 and 92, you actually wind up in two different categories. So understanding what you're dealing with, making sure that you do enough retraining, enough independent checks, enough monitoring becomes really, really important for public health. And finally, after we followed this cohort now for 20 years, and our height and weight, which we finally got right, and our IQ measurements that we finally got right, show us that actually persistently stunted children lose between 7 and 10 IQ points as compared to children that have never been stunted. And this, of course, has bearings on their future education, employment, etc. Now I'll come to overlap and interpretation. Vaccine preventable diseases. You would think we know how much of a disease we have in the country. We do, but we have many sources of this information. I'll show you one example. You have an investigation done by the Integrated Disease Surveillance Program, the same investigation done by the National Polio Surveillance Program. Different numbers of cases, different locations of cases being detected by two different government agencies. Whose figures do you believe? And how do you make policy when you don't know what it is that you are measuring? The NCDC used to do these beautiful graphs of outbreaks every week that showed you what you had. According to India, we have an average of between 7 and 20,000 cholera cases every year. But we have all these acute diarrheal disease cases that are never diagnosed. Every week there are outbreaks of this. When you look at actual cholera, that's a small bar. You don't see that many cases. But it seems very unlikely that acute diarrheal disease occurring in adults is not cholera. So again, our programs aren't measuring what we need. And then, of course, when it comes to impact assessment, we almost never do this. I've worked for a long time on rotavirus vaccines, and I decided that for once we had to introduce a vaccine and see what was going on. And this was particularly important because rotavirus vaccines don't work as well in India or in LMICs as they do in high-income countries. So we set up the very first vaccine impact monitoring program in all of these places, in all of these states, followed up lots and lots of children that were admitted to facilities, and we were able to show that when your vaccine coverage shown in the dotted line goes up, your incidence of, well, the proportion positive of rotavirus that is detected in a hospital starts to come down. And this is something that has been sustained over the last couple of years. So the vaccines are working. Now, the other problem that we had is when we worry about chronic malnutrition, we worry about how well vaccines work in those individuals. And in our effectiveness data, we were able to show that vaccines worked at what was expected, about 50% by and large in children who were young and not stunted, but in older stunted children, the vaccines did not seem to be working anymore. So we might want to think about, for those children, having a different approach, perhaps a booster dose. So finally, I'd like to end with, even with what we measure, we don't actually measure everything that we should be measuring in public health. This is capturing the value of vaccines. What we tend to look at is just a reduction in disease and therefore potentially better child survival. But if you look at this picture, you can see that the full value of vaccines for a society is very much more than just the reduction of disease. And we should be looking at mechanisms that allow us to capture this value for public health, to make the argument that these are interventions that are really needed for our populations. We live now in a rapidly changing world where capturing data is easier than it has ever been before. If we can use all of these tools that are available, there is no reason why measurements cannot get better. I'd like to just leave you with the principles for measurement in public health. We really should be measuring for outcome and not for process. We should measure for and with people, value the things that matter the most, be responsive, avoid over-claiming, and transparency and honesty are foundational, not enough of which has been seen in the last couple of years, certainly. Thank you.
I was just wondering, do you know why vaccines are not as effective in children who are stunted?
All oral vaccines don't perform as well in the guts of people who live in LMICs. One of the really interesting things is I think we should be looking at further stratification within LMICs, high-income populations versus low-income population. But those kinds of studies wind up being done very rarely. I've looked at CMC doctors' children, and in them, in general, the gut environment resembles a Western gut environment much more than it does children who live 5 kilometers away from them.
Leprosy been completely removed in this country?
No.
I keep getting different kinds of data.
There is a reduction, but not eliminated as is claimed.
Is it in the declining phase?
Yes.
Okay.
Ma'am, what is your recommendation about the booster dose? Should we go for that after 2 doses?
Have you been infected?
No, not yet.
Do you know that? So
Yes, ma'am. Whenever I got cold, I tested many times. Yeah.
So in general, if you are below 60 years of age, I don't think you need a booster yet. That is not to say that you might not need a booster at a later stage. but in generally healthy younger people, 2 doses of vaccine is more than enough to protect you against severe disease with any of the variants that we've seen so far.
Is there a deficit in the public health professionals in the country? Do we have much fewer than what we need? I mean,
Yes.
my impression is that we do, but could you estimate how many more we need?
That's not a question I've been asked before, so I can't answer that. I know that there are too few people and too few good people. Part of the problem is our educational structure, where we tend to push people towards super specialization when it really isn't required for managing the bulk of our health problems.